Hey guys, welcome to the last session of PGHE. This session is going to be looking at non-communicable diseases. It's going to be led by Dr. Arsene Hobabagabo. Dr. Arsene was a former UGHE student. He has done the masters that you guys are working on. He's currently a research fellow here at UGHE as well as a lecturer in the Department of Global Health. He has just finished a project working on the diabetes prevention, focusing on Rwanda. He was seconded at the National Institute of Health in the US. So he brings to this lecture a lot of knowledge in non-communicable diseases as well as diabetes. Before joining UGHE, Dr. Sen was working for the Rwanda Diabetes Association, where he also completed his practicum project. I hope you enjoy his lecture. And yeah, I will give it up to Dr. Sen. Thank you.
Hello, everyone. In today's PGP session, we will be talking about non-communicable diseases and global health. Let me start by introducing myself. My name is Arsene Hobabagabo. I am a medical doctor and a researcher. My areas of interest are non-communicable diseases, especially diabetes. Prior to joining UGHE as faculty, I worked as a consulting physician at the Rwanda Diabetes Association while undertaking my MGHD, the same masters you're doing now. I just finished a one-year fellowship at the National Institute of Health, where I was looking at the best diagnostic tools for diabetes in African-born populations. I am delighted to be giving you this talk today, and thank you for attending it. Let us start with some definitions. Non-communicable diseases, or NCDs for short, are also called chronic diseases. These conditions are not directly transmitted from one person to another and tend to be long. They are a combination of genetic, physiological, environmental, and behavioral factors. All NCDs are chronic, but not all chronic diseases are NCDs. For example, HIV/AIDS, although infectious, requires a lifelong treatment once diagnosed. This group can be difficult to define. The term NCD is very imprecise and encompasses a wide spectrum of conditions as well as a mixed group of risk factors and health interventions. The ambiguity of this definition might be behind the lack of urgency to address NCDs. When you look at this list of conditions, it can be hard to classify one into the communicable versus chronic disease silos, as sometimes they can be both. For example, human papillomavirus or hepatitis B virus vaccinations programs have been long an important part of control strategies for cancer that attack the cervix or the liver. That link between infectious diseases and NCDs is not only limited to viruses. NCDs policy has failed to address the issue of carcinogenic bacteria such as Helicobacter pylori that causes peptic ulcer disease or stomach cancer, or even carcinogenic helminths such as schistosoma that can cause bladder cancer, or even other parasites. This relationship between infectious diseases and NCDs is bidirectional. Traditional infectious diseases have been recognized to be risk factors to develop NCDs. We can cite here tuberculosis or bronchiectatic infections that can cause chronic lung disease, infective endocarditis that can cause heart disease, or even the latest pandemic of COVID-19 that has been shown to predispose people with NCDs to more adverse effects. This bloodline between infectious diseases and NCDs creates a false dichotomy between the two categories. They do share common features such as the long-term care needs and overlapping high-risk populations. There are notable direct interactions between the two groups. We can cite the association between certain infectious diseases and cancers, as well as the increased susceptibility to infectious diseases in individuals with NCDs. Therefore, NCDs should only be applied to illnesses that may or may not have an infectious origin, but that persist despite eradication of the initial infection. Beneath the loose umbrella of NCDs, the WHO classifies 5 key diseases and 5 risk factors. The 5 key diseases are cardiovascular disease, chronic respiratory diseases, cancer, diabetes, or even mental and neurological conditions. The 5 key risk factors are unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution. Now let us look at the numbers behind that NCD epidemic. NCDs are a significant and increasing cause of illnesses, disability, and mortality globally. They cause 41 million deaths every year, equivalent to 71% of all deaths globally. Cardiovascular diseases account for most deaths, followed by cancers and respiratory diseases. Particularly, NCDs have a high burden in low and middle income countries. Here you can see that between 2008 in yellow and 2030 in maroon, the burden of NCDs is projected to increase. Over the same period of time, the burden of infectious disease will remain the same or even decrease. In Rwanda, the WHO estimates that almost half of all deaths are attributed to NCDs. This burden is distributed as it follows. 3/4 are due to mostly communicable diseases, with the rest distributed in a long tail of NCDs, not dominated by any one disease in particular. Risk factors of NCDs are the following and are divided between high middle income countries and urban areas versus low income countries and rural areas. Whereas in high middle income countries and urban areas, economic development and its associated risk factors such as migration and adoption of harmful behaviors, changes in dietary patterns, and pollution are responsible for NCDs. For poor communities in low-income countries and rural areas, poverty and its associated challenges are the cause of NCDs. Here, the age distribution is younger and deaths occur more prematurely, with 85% of all deaths occurring between 30 and 69 years old. NCDs are caused by poverty, but also provoke it. The complications of the conditions and the conditions themselves carry a heavy load in terms of healthcare costs, loss of income, as well as the cost of the unhealthy behaviors for the families. The social determinants of NCDs are deeply rooted into poverty. As you can see here, almost all major NCDs arise from conditions associated with poverty, such as the treatment gap, but also infectious diseases and malnutrition. World leaders assembled at the UN General Assembly in 2011 recognized that NCDs were a major hindrance to development agenda worldwide and therefore belonged to the top of that agenda. A similar report was produced by the African Union in 2013, where they highlighted the fact that every year, over 100 million people are forced into poverty due to the exorbitant cost of caring for NCDs. Let us look now at how the implementation lessons from HIV/AIDS can influence the response to NCDs. The HIV/AIDS pandemic is comparable to this NCD epidemic in many aspects. What was initially regarded as another deadly exotic tropical disease is now a manageable condition. As such, policymakers and clinicians could learn a lot of lessons implemented in the HIV response. Some of those lessons are the high community awareness born from activism and advocacy, as well as community health workers' sensitization. The strong political engagement that resulted produced abundant funding as well as a centralized vision. The HIV response was done through a robust monitoring and evaluation systems, as well as specific human resource and supply chain planning. Concretely, the HIV/AIDS response could be referenced when it comes to prioritizing patient retention, with the introduction of a new and foreign concept of a lifelong treatment, as well as treating someone even when they do not have symptoms. They also addressed social determinants of health, such as stigma, the socioeconomic challenges that can arise from caring for a chronic disease, as well as the mental health issues. Human resources planning was done through decentralization and task shifting, where not only infectious disease specialists were caring for HIV/AIDS patients, but the care was shared throughout all levels of health systems. To implement those lessons, we need funds. When we look at breakdown of program-specific investment across disease areas, we see that although NCDs have a high burden, the funding is still lacking. On the other end of the spectrum, infectious diseases, especially HIV and malaria, still take the lion's share. But what are the reasons behind this disconnect between the burden and the funding for NCDs? First, these diseases are also common in high-income countries, the same countries that fund healthcare. Therefore, the investment will be concentrated in those countries, despite the fact that the burden is higher in low and middle-income countries. People also make the mistake of looking at NCDs as single conditions when they are relatively uncommon, and also requires many different approaches, no silver bullets. NCD care suffers from a lack of advocacy. The same doubts that were present when it was time to respond to HIV/AIDS epidemic, doubts of feasibility and sustainability, are also present, especially when it comes to low and middle income countries. But is sustainability really essential? At the beginning, people were opposing response to HIV/AIDS pandemic in low and middle income countries, advancing that prevention and traditional prevention methods that will focus on behavioral change and vaccination were the way to go. But today, we have been seeing that treatment is prevention and that this model is the one that works. Let us look now at the implementation challenges to NCD care, as well as some of the potential solutions. Looking at some diseases such as diabetes, rheumatic heart disease, and epilepsy, we can see that the challenges can be divided between healthcare system levels. At the home or community level, the main challenges revolve around self-medication with dosing and administration, as well as the management of complications, side effects, and adverse events. Patients are responsible for keeping track of their visits. Community health workers will be responsible for early detection of new cases and their referral. The primary healthcare system is where screening, primary and secondary prevention, as well as treatment of uncomplicated conditions occur. When these conditions require a more specialized care, such as hospitalization or lab testing, the care is switched to district hospitals and referred to central hospitals for the new cases that require a specialist. Caring for cancer is quite different. In terms of human resources, these conditions require a more specialized skill set with oncologists, oncology nurses, pathology, and radiation oncologists. The care is concentrated between district and referral hospitals that have enough infrastructure to do the necessary biopsies, pathology, and chemotherapy. The challenge becomes navigating the referral system and ensuring patient retention through geographical accessibility, mental health support, and reducing lost follow-up. Looking at decentralization through the 4S lens helps to grasp the challenges that may arise. Decentralizing NCD care to district hospitals or primary care levels requires trained clinicians, medical equipment, medication, and other supplies. All of these require space to be accommodated with clinic rooms and pharmacies. In these times of pandemic, this space needs to take into account the need to social distance for face-to-face services. Systems need to also be adapted to ensure supply chain and proper referral pathways while respecting public health guidelines to reduce nosocomial infection and COVID-19 community spread. Keeping these challenges in mind, measures such as task shifting help to expand the pool of human resources for health with the care shared between empowered persons, community health workers, nurses, and non-physician through supervision, delegation, substitution, enhancement, mentoring, and innovation. Another potential solution is the integrated care teams, which are groups of healthcare workers that deliver a set of interventions that require related skills and benefit from shared space and information systems. Rwanda is a prime example of how to integrate NCD care to already existing services at all levels of the healthcare system, both vertically and horizontally. In 2019, the WHO recognized the Rwandan model as the basis for PEN+, a strategy that combines both the task shifting and the integration approaches. It provides an integrated platform at first referral level hospitals to address priority conditions such as type 1 diabetes, rheumatic heart disease, and sickle cell disease, as well as palliative care for advanced malignancies and other conditions. PEN+ offers an opportunity to develop the leadership needed to train, supervise, and mentor implementation and expansion of chronic care services for more common and less severe NCDs at health centers. It builds on the WHO's PEN framework and ensures that all levels interact to take care of patients with chronic diseases. Patients are referred between levels as needed depending on illnesses, severity, and complexity, as well as mentorship and support that is established between all levels. To face the pandemic of COVID-19 and ensure continuity of NCD care, healthcare organizations have suggested a bigger place for digital health. Babil is an example of a digital health company that allows patients to call in and get consulted by a medical doctor by phone. Such services are bound to expand as we look to comply to public health guidelines and ensure a communication platform between patients and healthcare professionals. This may help patients feel empowered as they assure the majority of the care and avoid treatment interruptions, with patients referred to face-to-face services only when needed. It also allows clinicians to be able to request second opinions from more experienced specialists. Thank you for following this talk. If you have any question, please do not hesitate to contact me or the course directors. Have a good day.